a good session today to discuss how viruses work and discuss the nitty-gritties of the monkeypox as well. And after that, I think a very, very important topic that is lingering on from the COVID era is about intractable cough and how to deal with that. And again, Dr. Nidhi Dhawan is going to be discussing this topic. So we are I think this session is going to be very fruitful for a lot of us. Thank you, Dr. Nidhi, for choosing such relevant topics every week. Without much delay, I would hand over the session to you so that we can learn more about the said topics. Over to you, Dr. Nidhi.
Thank you so much, Dr. Meenakshi. I wish Dr. Kalsi was here because he actually texted me that he's having lingering cough. And, I was thinking, is Sunday ko kya kiya jaye? So I said, okay, let's do lingering cough. If you remember in the past, we've done one on neuropathic cough, but it was just in the passing. So I'm going to deal with it in a little bit more detail today. And I agree with you, monkeypox is not the next big pandemic, but we'll go a little bit into that also. The reason why I can say this with the confidence that I'm saying it is because viruses work in a certain way. So we've had several outbreaks in the past recordable history, starting from the year 735 Japanese smallpox epidemic to the present 2019 COVID-19 pandemic. And these epidemics have largely stayed restricted to geographical areas, not because they were restricted, but because people were not traveling to the level people are traveling now. So it's the human beings who carry these viruses wherever they go. So I don't know if you can see this. I have bought this book, and we are going to be doing the first few. I've read nearly 500 pages, which are going to be covered in the next 10-15 slides. So that's to understand how the viruses really work, how human beings respond to viruses, what are the immune responses to an invading pathogen like the virus, and how do viruses evolve. So the barriers that we are going to be dealing with are to the infection and to the transmission of infection to another host. So there are certain preconditions that are needed for a virus to establish itself in a host. There has to be sufficient viral load. There has to be a clear access to susceptible cells within that host. And there has to be an uneducated or an inadequate local immune response for the virus to establish itself. At a very basic level, the innate immunity and the local resident immunity resists establishment of a virus in a human host. There are skin and mucosal barriers. There are chemical and surface barriers at the surfaces where the human beings interact with any pathogen coming from outside. In terms of barriers to transmission, there have to be susceptible hosts for the virus to travel from one host to another. The transmission pathway between these hosts. So there has to be access to, Dr. Kalsi aa gaye. There has to be access to other hosts. So the medium, air, water, or food. And there has to be shedding of the virus through any of the means for the virus to travel to another host, whether this respiratory, skin lesions, body fluids, whatever the method. The innate immunity of the new host, again, has to allow the virus to establish itself into the new host, and the concentration of the load of the released viral particles has to be sufficient to establish in a new host. All these are very unfavorable in COVID, in SARS-CoV-2. So in the early host responses, there is an immediate response which recognizes the invader, aka the virus, and sounds an alarm to recruit forces. Those are the to sound the alarm to recruit the forces, that is the local resident cells, to restrict the virus or the invading pathogen to the site of invasion. Then the defenses are initiated through a recognition via the pattern recognition receptors and activation of downstream events, which can be cytokines and interferons. The immediate response is the intrinsic first ready response to localize the invader, and innate response is the one that is initiated after the warm-up when the pathogen is recognized. So it is like a reflex arc, and then the perception of the heat when you touch a hot object. The death of the infected cell can happen via apoptosis, autophagy, epigenetic silencing, and significantly cytosine deamination. Now, if the infected cell dies, the disease is over. But the aftermath of the disease, the response to the antigens that are still left in the circulation, can be the long-term things that happen with viruses. And many viruses have persistent long-term effects, not just SARS-CoV-2. If you remember the last chikungunya outbreak that we had, people were fatigued with joint pains and muscle aches for nearly a year or a year and a half after the initial illness. The initial response includes interferons, which suppress the viral replication and the viral release. It also initiates the cellular innate response, which recruits monocytes, neutrophils, macrophages to the site and activates the complement and the adaptive arms, which then are targeted to a specific inciting agent. So this is a photograph directly from the book. This book is by Jane Flint and Vincent Racanilio. They are virologists who are even running an online course, which anybody can access. So the viral receptors are usually in the cell membranes, and you can see here the receptors for herpes virus, polio virus, influenza virus. This Galaxy J7 Max, please mute kar lijiye. So there are either specific viral receptors, or there are the transmembrane receptors which allow for the virus to enter the cytosol, which are pre-existing and have other downstream effects. So it really depends on the ligand which attaches to the virus as to what the downstream effects are going to be. We know the basic definition of a virus is that it is a intracellular parasite, which means that it is just a particle of genetic material outside with no characteristics that make it living. It becomes living and pathogenic only when it enters the cells. So in the context of the SARS-CoV-2, the receptor is the ACE2 receptor aided by the TMP-RSS, the transmembrane proteases. The protease unwinds the spike, and the ACE2 attaches to the unwound spike. And then the virus is internalized by flattening of the cell membrane on the viral envelope, and the downstream events start. If we were to look at what are the things that can help us fight the virus, there have been several targets, and entry is one of the. So I was listening to somebody, an expert virologist, talk yesterday that there are some people who still believe that ivermectin works in SARS-CoV-2, and this is ridiculous. I think we need to leave our dogma aside and look at what the science says. And the science says that ivermectin is not being used for its antiviral properties. Ivermectin is being used for its anti-inflammatory properties. Also, ivermectin does loosen the connection between the ACE2, the TMP-RSS, and the spike. Ivermectin also works on these downstream effects. And those are the effects which decrease the inflammation. Camostat notably also works in fungal entry points. So it's a transmembrane inhibitor. If we look at what is the mathematics of SARS-CoV-2, then the virus takes approximately 10 minutes. This was measured for COVID-1, 10 minutes to enter the cell. There is a period of about 10 hours that you don't know that you are infected, or that you are so you're going to be the next hotspot. And then there is a burst size of 10 raised to the power 3 virions within 10 hours, which makes this a unique virus that in 10 hours you can, before you become symptomatic, transmit the disease to a new susceptible host. We've seen all of this in the last 2 years several times, but the seroconversion happens in about 10 to 20 days. The maintenance of antibody response measured for SARS-CoV-1 was approximately 2 to 3 years, but there were some studies which said that even 20 years after that initial infection, we have the doctors who treated at that time seropositive. The environmental stability in aerosols is for about 1 hour, and on surfaces can reach up to 10 hours. The basic reproductive number is typically between 2 to 4. That means one host can infect 2 to 4 new hosts, and that causes an exponential rise in numbers. So if we look at the downstream effects, if attachment can be inhibited by camostat and can be slowed by ivermectin, the internalization and then the proteolysis is inhibited by HCQS. The lysosome unwinding into the assembly and the replication are then inhibited by RNA-dependent RNA polymerases like lopinavir, and then the downstream effects by IL-6 and TNF-alpha blockers like tocilizumab. So there are several steps at which the viral cycle can be interrupted. Largely, if we look at the type of receptors that work for the bacteria, they are mainly The CLRs for the viruses, they are mainly the TLRs. The transmembrane receptors allow the virus to be internalized as an endosome, and then the downstream effects from the cytosol either into the nucleus or within the cytosol for some DNA viruses, like the pox virus, like the monkey pox virus. Then they can complete their life cycle either in the nucleus or in the cytosol within the cell. In terms of so this is for renal cells, but it works for almost every viral infection in the same way, that the nucleus, the mitochondria, and the cytosol are the place where certain proteins, certain substances become prominent. These become the damage associated molecular patterns, which are then recognized by immune cells like the dendritic cells and the tissue resident macrophages, which then establish a downward cascade for either phagocytic deactivation or apoptosis and phagocytic deactivation, but they initially cause cell death. The interferon 1 is an important interferon in viral cycle. They are potent antiviral cytokines, and they are produced by the innate immune cells. That's your neutrophils and the macrophages. They bind to the cell surface transmembrane receptors and use the JAK-STAT pathway to induce the expression of ISGs. These are the ones that code for other antiviral proteins, and the transcription factors are then, downstream transcription factors are then inhibited. So the type 1 interferon pathway, which is shown in red here, is the one that is prominent in SARS-CoV-2. Looking at how the innate system shifts to the adaptive arm, this is where the crossover happens from the dendritic cells and the natural killer cells. These are the ones that activate the T cells and the B cells, which go into the bone marrow and stay there for long-term memory. So it's the myeloid cells, the ones which come out of the bone marrow, which are the connection between the two. And if the neutrophils, the monocytes, and the tissue resident macrophages continue to persist in their inappropriate response, you get chronic inflammation. This persistence happens if the body is not trained to recognize the inciting agent. If this resolves with the presence of some defensins, some interferons, and some lysozymes, then the acute inflammation passes into the phase of healing. So the entire immune arm can have Th1, Th19, Th17, Th22, Th2, T regulator, or any number of T responses. Of significance is that Th1 protects us against viruses. Th17 is more pro-inflammatory, and Th2 is the response that causes persistence of inflammation. The T regulator cells are the ones which turn the arm towards resolution and anti-inflammation. The innate immune system, hence, recognizes some pathogenic patterns and some damage patterns. They cause release of cytokines, chemokines, which incites phagocytosis and pathogen elimination, or they activate the antigen presenting cells to reach the adaptive immune stimulation, or there is epigenetic reprogramming and metabolic rewiring to train the immunity and keep the innate immune memory alive. All this can go either into tissue inflammation, tissue repair, or immune tolerance. अगर आपको याद हो तो सर हमेशा कहा करते थे that we are going to have an epidemic of autoimmune diseases as this acute illness passes over, which is what I think we are seeing now. Now, adaptive immune cells are very special and they require a very tight junction. So they need two signals to be activated. They need the MHC and the naive cell T cell receptors to connect, as well as they need a CD40 receptor ligand binding in order for the antigen to be recognized and to result in release of cytokines. The antibody mediated immunity requires a third connection also. It requires the antigen to be presented also. So this is a very lovely dance which allows us to fight only the pathogens and not our own blood cells, not our own tissue cells. But when this system gets thrown out of gear, then our body starts attacking itself, which is what is called autoimmunity. The complement, so far we haven't really gone into the complement pathway, but the complement is in that arm somewhere between the innate and the adaptive, and it causes through the C3 and the C5 pathway, mainly in the lectin pathway, causes persistence of inflammation, phagocytosis, amplification, and regulation through the damage associated molecular patterns. The complement can be activated either in the classical pathway, which is activation of the C3, or the alternate pathway, which is again activation of the C3, and the MBL pathway. It's the triggers which are different in these. The C5 arm can be suppressed by, if you remember, we had done some anti-HIV drugs which cause suppression of long-term COVID effects, the CCL5 inhibitors and the CCX5 inhibitors. So this can be suppressed by the CCX series of drugs, the PMX series of drugs, and advoralimab. MAB is monoclonal antibodies. The C5 can also be, the downstream effects can also be blocked by mefenamic acid and other NSAIDs. There are a lot of monoclonal antibodies which are listed here for stopping it at the stage of the C5 rather than going into the activated C5 stage. Now, what is really happening is all the game of TNF alpha, IL-6, IL-1 beta. If we are looking at this, which drives the monocytes and the tissue resident macrophages, you have several downstream effects which are happening, and these result in all these immune actions. This happens in all viruses. The degranulation and formation of neutrophilic extracellular traps, which cause persistence of inflammation, the recruitment of eosinophils, which causes persistence of inflammation. But the IL-6, TNF alpha are set up in a self-perpetuating loop. That is why IL-6 block and TNF alpha antagonism are good targets for long-term inflammation, which is where Trental comes in. So the damage-associated molecular pattern receptors detect tissue injury. They pathogen-associated molecular receptors, the TLRs, detect microbial infection. These are present on all tissue leukocytes, like resident leukocytes, the T cells, the mast cells, and the dendritic cells. They result in downstream increase of IL-1 beta, TNF alpha, IL-6, CXCL8, IL-12, and the GM-CSF factors, which have effect on liver, hypothalamus, and bone marrow. The local effects here are increase in acute phase proteins like CRP, the rise in body temperature because the thermostat is knocked out, and there is increased neutrophil mobilization to fight the acute infection. This is the first response. That is why you will see the neutrophils rise and the TLC rises. As the viral infection gets established, the neutrophils start to fall and the lymphocytes rise. The local effects on vascular endothelium, on the parenchyma, and on tissue leukocytes all cause persistence of inflammation, and they decrease the rate of flow in the blood vessels, which is why mild to moderate exercise helps. The cytokines can work on the fat cells, on the liver cells, they can work in the system, they can work on the muscle, and they can work on the bone. The local effects are all towards persistence of inflammation by decreasing glucose tolerance, increasing insulin resistance, decreasing B cell function, increasing lipolysis. That is why when somebody is ill for a long time, you find that they lose weight and they look weaker. But it also increases triglyceride synthesis. It also increases de novo lipogenesis and decreases oxidation. So there is, at a cellular level, abnormal sugar and fat metabolism. So the cytokine storm is when there is inappropriate stimulation of the immune system, either because it does not recognize a pathogen, or because when it recognizes a pathogen, it cannot stop the stimulation at the right time, or because there are other factors which are causing persistence. What is happening here is that the cytokine storm results in a hyperdrive of the immune system. There is a failure to resolve the inflammation and return to the resting level. We have seen all these pathways earlier. Of significance is the nuclear factor kappa beta pathway, where the ivermectin is working, the JAK-STAT pathway, which we have seen earlier, and the mTOR pathway, the mitochondrial pathway. The acute systemic inflammatory effects are because all these pathways are involved. The secondary organ dysfunction, and when these persist, multi-organ failure and death result. So the Th1 response recruits macrophages and dendritic cells. It happens in the presence of interleukin 2, IL-2. Th2 response happens in the presence of IL-4, IL-5, and IL-13 and recruits basophils and eosinophils. This is a largely allergic response. The Th9 response needs interleukin 9 and 10. Th17 requires primarily interleukin 17, and the cytotoxic T lymphocytes require interferons, perforins, and granzymes. All these cell targets have their own downstream effects. All these, when they persist, in fact, eosinophils have now been implicated in oncogenesis also. In an acute viral infection like influenza or hepatitis A, the viral titers go up and come down. In some latent viral infections like herpes simplex and varicella zoster, which stay on in targeted tissues, in this case the nerve tissues, it goes up, comes down, but doesn't get eliminated completely. It stays in a latent state and then can be activated by an immune trigger, but not to the level that it was in the initial infection. There are some chronic infections like hepatitis B and HIV, where it can show an initial surge, then it goes to somewhat lower levels but doesn't get eliminated. In hepatitis B, it homes to the liver. In HIV, it stays in the immune cells, and then HIV can get activated by immune triggers, but HBV has further downstream effects on the liver. There are some unconventional viruses or targets which cause somewhat late diseases like EBV, which continue on late into life. So this is just the initial response of the body to a virus. The virus is going to be recognized by pathogen-associated patterns. It is going to be internalized if it finds the right receptor. Then either in the cytoplasm or in the nucleus, it is going to produce its own copies. It is then going to be released into the surrounding area. The death of this infected cell is going to release some damage-associated molecular patterns, which are going to be recognized by other immune cells, which will rush to that area. The sudden surge of these cellular events is going to result in production of interferons and cytokines. These interferons and cytokines work at a local level to suppress the viral infection, and at a systemic level to recruit more and more parts of the immune system so that the viral infection can be fought more efficiently. In the initial phase, because of these cytokines, there is fever, there are other downstream effects. If these cytokines and interferons persist in the body, if the body is not able, or if there is any cross-reactivity between the pathogen-associated molecular patterns and self-antigens, then there is a persistent inflammation which might even attack body's own tissues. This can include, but not be restricted to, certain nerve tissues, certain tissues in the heart, in the lung, in the kidney, and in the blood vessels. And we see that all these targets have been found with SARS-CoV-2. The reason why it seems like SARS-CoV-2 is affecting all the organs is because ACE2 is a receptor which is present on almost all cells of the body. So once this machinery is activated, the host goes through that acute viral illness. If the host is able to contain the illness, he moves into resolution. If it is not completely eliminated, the threat is not completely eliminated, he moves into chronic inflammation. The drivers of chronic inflammation appear to be TNF alpha and IL-1 beta. We will go further into the downstream effects of nuclear factor kappa beta and the cellular events and the glucose metabolism at subsequent sessions. But I thought it is good to understand that a virus needs a susceptible cell, a cell that does not recognize it, is not immune educated to fight it, and that in the SARS-CoV-2, that phase of the viral cycle is largely over because we are now educated to recognize the SARS-CoV-2.
Hello. You are moving slides or not fixed?
No, अभी मैंने monkey pox पर fix किया है.
Fine.
I just wanted to conclude the previous section.
Yeah, okay, fine.
So if our body recognizes the SARS-CoV-2 and its related antigens, then human beings as a species are moving towards resolving this pandemic to its next state of endemicity. And that happens because of, again, certain viral properties, which we'll go into as we deal with monkeypox. Is monkeypox the next big thing? The short answer is no. So if we want to skip over, we can skip over all the details and say the short answer is no. But so in the month of May itself, we have seen world over about 400 cases of monkeypox. 100 of them have been seen in UK, 12 in Italy, and 9 in US. This is not the entire tally. That is why they don't all add up to 401. There have been outbreaks or so-called outbreaks in various countries in Europe mainly. But monkeypox is not new. That's the first difference between monkeypox and SARS-CoV-2. SARS-CoV-2 was a novel virus. Monkeypox is an old virus. The second difference is that monkeypox is a DNA virus, which is much more stable than SARS-CoV-2, which is a RNA virus, which is largely unstable. So what is monkeypox? How do you identify it? You should all, we all should be able to identify monkeypox because we were able to successfully eliminate smallpox because of certain strategies that we followed. Monkeypox belongs to the same family of viruses, the Poxviridae, and is much less lethal, much less pathogenic than the smallpox virus. How to identify it? The typical pox vesicles, which most of us have seen, the Badi Mata, as Meenakshi pointed out in her talk yesterday, but they are all in the same stage of development. Unlike chickenpox, which is of course a slightly different genus, but in chickenpox you will find that koi vesicle bada hai, koi chota hai, koi phat gaya hai. But in monkeypox, they are all in the same stage of development. Monkeypox begins with fever, headache, and body pain, and is not infective till clinical picture comes up. Whereas in SARS-CoV-2, the patient is infective even before he starts becoming sick. Recovery is usual. It belongs to the same family as smallpox, but is much milder. The smallpox vaccine is probably protective. So most of us, I have been vaccinated for smallpox. At the bottom of my foot, there is that scar. किसी को यहाँ पर आर्म में दिया जाता था, किसी को पैर में दिया जाता था. So हमारी generation तक 1977 I think or 75, Dr. Arora will be able to tell me more correctly, smallpox vaccination हमने बंद की थी, but तब तक so most of us would be vaccinated. The other difference is that it homes to the lymph nodes, monkeypox, and the lymph nodes are swollen and tender early in disease. Is it a sexually transmitted disease? It is a disease of contact, not necessarily sexual contact. It is a disease where the skin surface or the respiratory surface or whatever that barrier to the environment needs to be breached, and micro abrasions can happen during a sexual act, and that may be the reason why mostly we are finding it in a sexually transmitted manner. As yet, it is not designated a sexually transmitted disease like HIV. It is rather transmitted by fomites, that is soiled bed linen, soiled hankies, towels, by droplets. So if somebody coughs or sneezes, there are droplets in the air around, and by infected surfaces. The latest wave of monkeypox has been found largely in Europe and in United States and Canada. Otherwise, monkeypox since 1958 has been present in this horn of Africa. It is of two types, the West African and the Congo Basin strains. The present strain appears to be the Congo Basin strain. The monkeypox outbreaks have been, like in 1970, 75, 78, 80, 81, 87. So there have been several outbreaks. It just looks like we are more sensitized by the last 2 years to observe these 400 cases and call it an unusual thing. It is not unusual. What is unusual is it is happening in Europe and in US. So if we look at viruses, then you see the two main divisors are DNA virus and RNA virus. Coronaviruses, the SARS-CoV-2 family, are RNA, and pox viridae, monkeypox, is DNA. This is the first big difference. The second is that SARS-CoV-2 was a new virus, and the pox virus, monkeypox virus, is an old virus. We are educated against it. So if you look at DNA, viruses are much bigger in size, much more stable. The replication happens in the nucleus. This replication happens in the cytoplasm. It uses endoplasmic reticulum, this one. This one uses nuclear assembly methods. This has a much lower mutation rate. This has a very high mutation rate, which is why till date we haven't been able to find a successful vaccine against HIV. The replication is very accurate. There is a high error rate in RNA viruses. This can be double-stranded or single-stranded DNA. This can be double-stranded or single-stranded RNA. It can be positively wound or negatively wound. But the examples are adenoviruses, ones that we have used to carry the SARS-CoV-2 spike on in AstraZeneca vaccine, Covishield, herpes viruses, pox viruses, parvoviruses, and the hepadnaviruses, the hepatitis B. The RNA viruses, retroviruses, orthomyxo, toga virus, picorna virus, Rio virus, all these, if you see, are causing short-lived diseases that the body gets educated to. So in terms of two very basic factors, the fact that monkeypox is not a new virus and that it is a DNA virus, it is unlikely to cause the next major outbreak yet, because it is happening in unusual locations. It is important to be aware and we can follow very comfortable ring isolation strategies, ring vaccination strategies, whereby you isolate the case of monkeypox and vaccinate the people surrounding that case, and you are done with the outbreak. So unlikely that monkeypox is going anywhere big. I certainly hope that मेरी अपनी नजर ना लगे इस statement पर. So we'll come to now that topic which is largely on a lot of people's minds, neuropathic or neurogenic cough. This is a sensory cough. We are coming up with a lot of patients who do not respond to any of the usual methods of treatment of cough. And it appears that there might be other factors coming into play. It could be a neuroinflammation, it could be a neuroimmune response, and it could be persistent viral particles. It could be a lot of things. So this was a very interesting paper that I came across. It is a 2016 paper, which was talking about the prevailing practices of management of dry cough in India. It was a paper that went into how physicians generally look at the topic of dry cough. You obviously identify the obvious cause. You consider any red flag symptoms suggesting some disease. Then you do focus testing for the usual culprits, asthma, acidity, and sinusitis. And then you do comprehensive evaluation of the patient for rarer causes if nothing seems to be working. And then you... So potential treatable traits for persistent cough are eosinophilia, airway obstruction, acid reflux, non-acid reflux, nasal inflammation, laryngeal dysfunction, and bacterial infections in children. It is important to know your cough. There are some indices that people use to assess cough severity on patients' health and overall symptoms. This is also an Indian report. This is a good way to... I think Galaxy 7 is not getting muted. If it can be muted, please mute it. The cough is otherwise a protective reflex and is to protect our airways and our body to expel the inciting irritant. In COVID, the lung innervation is in the eye of the cytokine storm, and the neural inflammation seems to cause persistent cough. This cough is not restricted to just the lungs, but also can be present from the throat. These symptoms that are associated with dry throat are soreness, sleep disturbance, sometimes fever if there is an acute illness, and sometimes the coughing is so violent that you end up having vomiting. The frequency of symptoms trigger can be, if you are talking too loudly, sometimes people don't know what is causing it, sometimes exercise, eating, temperature change, some smells, taking a deep breath, sometimes being exposed to smoke or mucus. So these are the usual triggers that people say they face. The first line of treatment usually is dependent on an identifiable cause. The asthma is generally treated with treatment of obstruction. The acid reflux is generally treated for acid. The postnasal drip is generally treated with antihistaminics. The post-infectious cough can be usually for bacterial infections where you will use antibiotics, and sometimes cough and cold preparations which suppress the symptoms, and a respiratory tract infection, that means lung infection, you would again use antibiotics for varying degree of time and cough and cold preparations. So this is the usual way in which you would treat dry cough in a patient. Interestingly, if you look at a patient of acid reflux, you will find these follicles at the back of the throat. You will find some congestion on the tonsillar pillar. You will find some swelling, redness on the uvula. You will find in acid reflux also the tongue is coated. And you find that all these symptoms get resolved in a patient who is successfully treated. In a patient who has postnasal drainage, you find that the mucus sticks to the surface of the vocal cords, which are otherwise normal. In acid reflux, you also find, so these are the vocal cords, which are only mildly swollen. You will find that the back of the larynx, the arytenoids and the interarytenoid area is very inflamed. So this is an algorithm that they follow. The red flag symptoms, you will do the usual history taking. An ENT surgeon would do nasal endoscopy, and if the nasal endoscopy is normal, a laryngoscopy. You generally come up with the usual diagnosis and you treat those usual things: allergies, reflux, and asthma. In COVID, none of these usual things is working. So the persistent cough and the COVID-19 or other post-viral coughs are special in the sense that they do not respond to the treatment of the usual suspects. Dr. Bastian is a very dedicated and passionate person somewhere in the US who's treating only neuropathic cough for last several years. So he says that cough can be divided into 3 phases. One is during the illness, where the airways are going through the hurricane of the infection. The cough is the biological response to clear the illness. Then the early post-recovery cough is when the hurricane is over, but the trees have fallen, there is debris in the landscape, and you have to clear all of that. But the late phase cough is when the patient has recovered from the illness, but that niggling irritation is persisting. This is a sensation. So this is, in his words, a sensory neuropathic cough with no biological purpose to clear a disease or an inciting agent. It is initiated by a sensation that might feel like a drip, a tickle, or a prickle. It is out of proportion to the mucus that ends up being produced, and it has triggers like talking, laughing, cold air, even swallowing or change of position can sometimes trigger a bout of cough that doesn't go away. The treatment of usual suspects, that of allergies, asthma, and acid reflux, does not work. The usual cough suppressants, including codeine, do not work. So the pathogenesis here appears to be the damaged vagal nerve endings in the lung and in the throat. And the nerve agent recovery, the nerve damage recovery agents hence work in these patients also. These are amitriptyline, desipramine, gabapentin, citalopram. If this first line doesn't work, you can try steroid injections in the site of trigger points. Easier than a steroid injection into the trigger points would be to use a local anesthetic spray. Xylocaine spray आता है जो dentists बहुत use करते हैं. Or even a capsaicin spray, but we don't have capsaicin sprays in India. The cough typically presents as a feeling of something stuck in the throat or globus, dry, hacking, uncontrolled bouts, frequent throat clearing, ticklish feeling at various levels in the throat. It can happen at the level of the base of the neck, where that point of the sternum and the neck is there, sternal notch. It can happen somewhere in the middle of the throat, but it can also happen at the back of the mouth. Sometimes the patient could even feel like his voice is different, and that it looks like, there is wetness in the voice, but there is no phlegm coming out. The smoker's cough, the pollution-related cough, partly respond to antihistaminics because histamine seems to be the final common pathway for all these things to happen. But these also don't fully respond to antihistamines. So these are the typical cases of sensory neuropathic cough, which responds to, so I have been giving for patients who do not respond to the usual means. And this is long before COVID, by the way. I mean, I've been treating this kind of cough for a very long time. It is not just COVID which causes this kind of cough. So I have been using gabapentin. I have been using a combination of gabapentin and nortriptyline, gabapen NT, in some resistant cases. I haven't really used citalopram, but I have used local anesthetic lozenges and local anesthetic sprays in many patients. So these are, and within a week of doing that, sensory neuropathic cough becomes 90 to 95% better. If you look at the picture of a patient before the bout of cough, this is like a normal larynx. And look at the picture of a patient after the cough. There is so much trauma. There is so much inflammation in the throat that it can even result in hoarseness. So typically, there is something that causes you to activate the cough reflex. There is the urge to cough, which is physiological. It is protective. And you just go into resolution by removing the noxious stimulus. Or there can be such violent coughing that there is neural injury. There can be neural injury from some environmental pollutants, chemical irritants, oxidative stress, some drugs too. So whenever I see a middle-aged patient whose cough is not resolving, the first question I ask them is, are you on any antihypertensives? Because ACE inhibitors are a very prominent trigger for unresolving cough. And this cough will not go away with anything. Kuch bhi kar lo, unless you change. So I have to send them back to the physician that please change this antihypertensive, else this cough is not going away. The Pathological cough results in local neuropathy, where the throat, the chest, and the voice all get involved, or a systemic neuropathy where there can be esophageal, cardiac, or even sensory motor peripheral problems that come into play. So the cough hypersensitivity syndrome can be a combination of local and or systemic neuropathies. The cytokines here are again IL-1 beta and TNF alpha. So I would say that if nothing else is working, then consider TNF alpha blocking agents like Trental. IL-6, again, TNF, IL-1 beta, interferon gamma. So this is, the resolution of inflammation by the usual ways, whereas there is a vagus nerve damage, and there is that chronic persistent inflammation, so that vagal reset will work, and allowing the nerve cells recovery time will work. So immunity is a very nuanced dance. It's an orchestrated piece of music, and we are a part of a symphony we don't know we are playing. We are a part of a dance we don't realize we are moving in. And to be aware of our own body, to be aware of our own, the things which are in our control, is the first step to promoting health. The three big legs on which good health can stand are an anti-inflammatory lifestyle, which means relaxation, vagal, anti-inflammatory foods, etc., etc. A little bit of movement and exercise to keep the body in hormesis, so you don't go beyond the point of diminishing returns. You exercise as much as keeps your body healthy and doesn't result in persistent inflammation also. And the third, but I would say this third outweighs the other two, is good quality sleep. In case of chronic, intractable, and persistent cough, unfortunately, sleep also gets disturbed. So recovery is further delayed, and you are in the eye of a spiral which does not recover. So we need to find whatever works towards recovery. My protocol is to start with H1, H2, H3 blockers, add bronchodilator. Next step would be to add gabapentin. Next step would be to add nortriptyline. Next step would be, or somewhere in between, I would say, before I add even gabapentin, would be to give xylocaine lozenges. But in the meanwhile, promote an anti-inflammatory lifestyle.
Thank you, Dr. Nidhi, for those, that brilliant presentation. I've been reading up on monkeypox lately, and there were quite a few salient points that even, were eye-openers for me. So thank you so much for working so hard for all of us and keeping us in the loop of with everything that's going on. Of course, intractable cough is something that I think every physician has been struggling with in the COVID era, and your take on it really, I'm sure it's helpful to most of us. The floor is now open for questions, so if anyone would like to take up questions or discuss something, we'd be happy to do that. Some compliments for you in the chat box. And
I'm just opening the chat box to see.
Dr. Lee, how frequently you get this sensory neuropathic cough? Because
Often,
we have never think of this condition at all.
Sir, often enough, and especially post-COVID times, more often. Often enough because जो patients बहुत violently cough करते हैं ना, उनको local damage हो ही जाता है, and then nothing works. So I would say that trying local anesthetic lozenges, and if that makes a difference, you're dealing with sensory neuropathic cough. So it would be difficult to say it is 20% or 30% of the usual, but अगर smoking की history है, अगर बहुत ज़्यादा frequent hacking cough है, तो कुछ ना कुछ neuropathic element है. और दिल्ली में तो पोल्यूशन तो है ही है.
वही बात है, सबको स्मोकर या पोल्यूशन का बोल के चुप करा देता है. So it was eye opener for us. Something new learned. This is certainly that.
Thank you, sir. But यही है कि कई बारी ना, I mean, this is something which I feel, and I think maybe the wrong forum to say this, but I think unconventional treatment methods work. So there are some people who will respond very well to breathing exercises, chiropraxis, or even to acupuncture, because even the posture of the neck makes a difference to how well the airway is opening. Dose of Trental, Dr. Poonam is asking. I generally start as 200 mg twice a day, which is like really the minimum, because 400 mg se kam to tablet bhi nahi aati, so I start half tablet morning, evening. But you can escalate the dose to at least 400 mg morning, evening. Trental is a rheostatic agent which actually improves the blood flow and is anti-TNF alpha, so there is absolutely no side effect to it. GABA neuron, you would start at 100 mg, then escalate to 200 mg, then 300 mg once a day, then twice a day, then thrice a day.
And for how long we can give Trental?
You can give Trental for, so Trental ka effect aane mein hi 1 hafta lag jata hai, so don't stop before then. Then you can do your clinical titration and see what is working. 3 months. Why I say 3 months? Because most of these cells which drive chronic inflammation, the inappropriately stimulated monocytes, the tissue resident macrophages, and the RBCs with TLR3, all three have a life cycle of 120 days. So you have to give these agents for at least 3 months, plus for the newer progeny to be healthy, 1 month more. So 3 to 4 months, I think, is needed, but you can take your clinical judgment into play and see how long you would like to keep this on.
डॉक्टर निधि, गाबापेंटिन को 300 milligrams 3 times a day करने के बाद नॉर्ट्रिप्टिलिन ऐड करोगे कि बीच में?
नहीं, मैं बीच में कर देती हूँ. मैं 300 mg 3 times a day में ना बहुत drowsiness होती है. So what I do is that I will go for GABA neuron 100 mg, then 100 mg twice a day. But Dr. Bastian says he does 300 mg thrice a day also. So I don't do that.
बड़ा fogginess होता है ब्रेन में. के लिए elderly के लिए हम इतनी डोज नहीं कर सकते.
So I don't do that. I agree. I go to 100 mg once a day, and then I shift to Gabapin NT once a day.
Yes. Acha, once a day only.
Once a day only. Night, once a day. I do that because most of our patients are, you know, agar koi professional hai driving karke ja raha hai, you can't have a foggy brain. And plus,
Yes,
वैसे ही brain fog हो रहा है with COVID, so you don't want to add to fogginess.
And
नहीं, और वैसे भी अगर elderly है या above 60 है, तो I think once a day at bedtime is a better dose.
Yes. Dr. Arora was saying something.
yes, Treatable can be given for long term because that intermittent claudication हम use करते ही हैं.
Yes. और उसके कोई side effects नहीं है sir. Pentoxifylline is a phytonutrient otherwise. It improves mitochondrial health. It is anti-TNF alpha. It improves circulation. It improves viscosity. So it has a lot of benefits.
A lot of silence here. I was
I think we are over
the first.
Dr. Meenakshi, आपकी voice
What's that?
clear नहीं है.
आपकी voice कट रही
मेरी
थी.
आवाज.
आपने अभी जो बोला एक बार ही रिपीट कर दो. Is Dr. Kalsi here?
अभी तो नहीं लाया.
वो आए थे ना बीच में.
Yes.
So that is what happens, when we talk to each other and we realize that something is troubling one of us, then we go deeper into the issue and see what can work. And that helps a lot of us. So, sir, आपके थैलेसीमिया टॉक के बाद ना मैं सबका सीबीसी उसी हिसाब से देखने लग गई हूँ.
Thank you, madam. ये अगर आप कहो तो सिकल टेक करते हैं because 17th June is a sickle 19th June is a sickle day. So but 19th I'm busy. 19th के बाद next week कर लेंगे 26 को.
ठीक है सर, क्योंकि वो वाला वीकेंड आई एम इन चेन्नई, सो अगर आप करोगे तो आई विल ज्वाइन इन द टॉक, बट आई वोंट बी एबल टू डू द टॉक.
ठीक है, 26 का आप सिकल नोट कर लो.
मीनाक्षी, आपने नोट कर लिया?
26 जून.
Dr. Meenakshi is not to be seen.
No, she's there. I can see her.
Yeah, लेकिन
she's trying to figure out why her voice was getting choppy.
Just one point, ma'am.
Yes, sir.
Among antihypertensives, it's a quite important history which you were telling. Not
sir.
only Ramipril, even amlodipine is the other culprit which should be looked at.
Sir, I am educated in this because मेरी internship में मैंने ACE inhibitors के बारे में सुना था, तो वो मेरा हमेशा से रहा है. I mean, even in my PG days, I asked that question if somebody is on ACE inhibitors. But if amlodipine is also one of the culprits, then I am also educated.
But I have not heard of it. It's true. I'm not sure.
Amlodipine?
I've seen a number of cases.
I don't know about amlodipine, but ACE inhibitors, so
it is documented, but
Amlodipine is very rare.
किसके बारे में? पहले कभी सुना नहीं हमने.
मैंने भी नहीं सुना, so I don't know.
Just I've seen cases. So I've changed the drug and the response was bad.
And very rare side effect of amlodipine is bleeding from gums also.
Yes. That I've heard.
It's quite rare.
That I've heard.
Amlodipine is also autotoxic, isn't it?
Yes, it is.
Yeah,
it is.
so that's the the thing that I remember. So I was just saying that in the first wave, I remember that there was this third year medical student who came on the OPD and he was panicking and he's like, Dr. Meenakshi, I've gotten globus pharyngitis. And I was, just taken aback because, of course, you know about it, but some things just go at the back of your mind. But somehow, globus pharyngitis is something that was never discussed in the COVID pandemic. It's not. It was not something that was talked about. So, do you think that because, of course, in the etiology, if you do read up, pharyngeal inflammation is a cause of
one of the causes.
So, can we say that this is one of the signs?
Yes, I think so. Yes.
Yeah. So I was a little taken aback because of course they were still the third year students.
were reading about it at that time. And, I was, because I'd never read about it in the context of COVID. So today your talk just reminded me of that patient. So I think no more questions and no more discussions left for today. Let's call it a day and take up another session next week. Thank you, Dr. Nadi, for working so hard for all of us. And a big thank you to all of you for joining in and keeping this show alive. We're grateful for your presence. See you all next week.